Hello, everybody. Thank you guys for joining us this afternoon. We appreciate everybody coming out. This looks like a great turnout today for a great lineup. So I also just a couple of housekeeping things. This is, I know on the program, I think this was billed as a 45-minute session, but this is a 90-minute session. So we will be going till 4:30. And I hope you guys can all stick around because it will be worth it. So today we're going to be talking about advanced HIV disease. Oh, sorry. Thank you. Better? Okay. So again, 90-minute session and from the top. So we are going to be talking today about preventing deaths from advanced HIV disease, a topic that we have been talking about at several ICASAs and have gone way back on it and have come a really long way on. So I'm excited today to have our panelists and presenters discuss some of the progress we've made, some of the gaps that still exist, and some of the potential solutions through partnership that we want to talk about in the future and start the conversation for future ICASAs. So up first, and for the structure for today's session, we have an initial speaker. We'll have two panel discussions, followed by a Q&A and a closing statement. So without further ado, I want to introduce our first speaker, who many of you guys will know. She is a rock star in the field of mycotic diseases and advanced HIV disease. Many of you have seen her glamour shot, I'm sure, at the exhibition booths. It's also her birthday today, so if we have time, we'll sing. Thanks. Thank you. This is Dr. Rita Oladele.
So thank you, Greg, for the very kind introduction. Today we are going to be looking at advanced HIV disease. Our focus is on the implementation of the package of care, the successes, the challenges that we've had, and what do we think going forward we need to do, because we all know that we need to end the HIV pandemic by 2030. Where does advanced HIV disease fall in here? We have targets of 95, 95, 95. What are the targets for advanced HIV disease? So I'll be presenting a 10-minute experience from our experience from Lagos. Can we have the next slide, please? Next, please. Okay, so I tell stories a lot. So I think you go back one slide and then. Okay, so I tell stories a lot because I discovered that stories, you don't forget them. You can forget the statistics, but you don't forget the stories. So in the last 2 months, I've been on the field working and I've been to a number of sites. So I want to share two experiences from those sites. The first one was about a 17-year-old young lady. She had been diagnosed with HIV as a child, defaulted treatment, and then represented with symptoms suggestive of TB, but also with some cerebral involvement, that's brain, in quote, involvement. In the facility, there's an ART clinic, but this story wants to highlight what the gaps are. So this young girl, they did chest imaging for her. It showed that features suggestive of TB. Can we go to the next slide? And then they also did an MRI for her. It showed raised intracranial pressure. So the first things the doctor did was they thought, okay, this child had TB. So they started treatment for TB. She wasn't getting any better. And then they relooked at those imaging and said, it just might be that she has atypical pneumonia. So they included treatment for that and she wasn't getting any better. And then they decided with the cerebral features emerging, she began to have seizures and all that, they think that she probably has viral encephalitis. And they started that and she was on ARTs and eventually she died. So at post-mortem, they needed to know what was the cause of death. At post-mortem, samples were collected from the brain and they grew cryptococcal neoformans. So she died of cryptococcal meningitis in the year 2023, where we have advanced HIV disease package of care that have been rolled out in 17 countries in Africa. Next slide. So the next case was, this is from central Nigeria, this is from southeast Nigeria, about 600 kilometers away from the first site, was that of a young man, 28-year-old male. It was ART experience. He had been having these headaches. And I always say one of the challenges we have with headaches, I mean, I'm sure some of you have headaches right now, right, from the heat. So if a patient comes to clinic and says, I have headache, you're like, okay, so what else? Because we all have headache. The economy brings headache. Everything brings headache. Yes. So he presented with this headache, but he had marked weight loss, was not doing very well. His CD4 count was 94. They did a serum crack test because they have an ART program in that facility also, and it was negative. So they went ahead to do brain imaging scan, that's MRI, and they saw what they reported as a space occupying lesion. So the surgeons went in, took some samples, sent to the histopathologist, and the report came back that it was a cryptococoma. So based on that report, they did a repeat serum crack, and they then did serial dilutions on it, and they were able to get it positive. He was started on liposomal amphotericin B. But don't forget, this patient had been sick for 1 month. Commonest presenting symptom for cryptococcal meningitis is headache. Okay? But at no point was liposomal lumbar puncture done. The cause of death in this patient was cryptococcal meningitis. And it's a recurring decimal. And it is unfair that in 2023, anyone should die of cryptococcal meningitis because it's a treatable disease. We've done in country, we have done courtesy of CHI, we have done implementation package of care. We started up with a pilot and then we scaled up. So over 2,000 sites have been brought into the program for the implementation package of care of advanced HIV disease. So why should someone in such a country die? Well, I'm just giving 2 cases. There are several others that might have slipped through the cracks. We don't know. But this is a preventable death, and it is unfair. If you look at the first site, the challenge in that site was the doctors, because the patient that is acutely ill comes in through the accident and emergency. Okay? The ART doctor does not get to see that patient. So there's a gap. So despite the fact that that facility had crack test available, the facility had liposomal amphotericin B on ground, the patient died of cryptococcal meningitis. In the second site, lumbar puncture, they showed raised intracranial pressure, but at no point was lumbar puncture done for this patient, which is in our guidelines. So there is a disconnect, and I hope by the time we leave here today, we can come up with solutions to address that disconnect between the clinicians and the ART program. The next slide, please. So we all know advanced HIV disease. We all know that there have been historical scale-up of the ART program. I mean, patients being taken into the ART program, high numbers, and then the deaths have dropped. But if you look at that graph, you can see that the number of deaths have slowed down. And we want to know, why is it not as dramatic as the scale-up? The next slide, please. In Nigeria, we did the same thing. We looked at our data. We have, the 95 target. We've gone very far. We've done well. And you have about 1.4 million, 1.5 million people that have that on ART. But however, if you look at the deaths, the second one there, you see that our deaths seem to have stagnated. Why? Next slide, please. So I liken this to a lovely success story. We've come a long way, but we have reached a roadblock. What accounts for this roadblock? Why? Lovely scale up with a roadblock. The next slide, I'll give you some reasons. Next slide, please. So we have a number of things. We think that we were able to deduce that delayed HIV diagnosis will contribute to that roadblock, delayed enrollment in care and ART initiation, non-availability of diagnostic and treatment for opportunistic infection was something that stood out strong. Okay, and then you had other things like patients abandoning care and being lost to follow-up. All these things contribute to HIV disease progression and advanced HIV disease. Next slide, please. So for the opportunistic infection, the session before this focused on TB. It's known to be the leading cause of death in this population, but following that closely is cryptococcal meningitis. Next slide. And then on the continent, we have 17 countries that have already started implementation of the package of care. For CRAG screening, we have some doing reflex screening that have been recommended in their guidelines. And then for others, the screening is desirable where the resources permit. But what is critical is that we have screening being done. We have progress being made, but we have some hitches. Next slide, please. So in my country, if you look at this, you can see that for AHD diagnosis, we have in the cascade 79% testing coverage. For the TB lamb, we're at 78, and I think that is sparse. Okay, but for the CRAG cascade, it's just 68%. And interestingly enough, in that 68%, only about 30% of them have lumbar puncture done so that they could have CRAG done on the CSF. Next slide, please. So globally, we are looking at 95, 95, 95. By 2030, we want to end the HIV pandemic. And then we want new infections to drop to as low as new 200,000. But we don't have any targets for advanced HIV disease. And if we do not have that target, we're not going to be able to measure our success or where we plan to get to. And that will affect the outcome of this. Next slide, please. So the lessons that we have learned from our facilities, I'd like to share. One is that disconnect between the clinicians and the ART clinic, and that gap needs to be bridged. And then also at the level of community ART initiation, the AHD package of care there needs to be strengthened. And we discovered from our program that same-day CD4 count is possible. That means you can initiate ART same day if you screen for opportunistic infections and they are absent. And the management of cryptococcal meningitis requires lumbar puncture, both for diagnosis and for therapeutic purposes. And it's something we need to strengthen. And then we also noticed that there was poor AHD service for experienced ART experienced patients and patients that are failing treatment or those that are lost to follow-up. But critically, we also discovered on the facilities that there was this disconnect. The AHD package of care was being run as a parallel program to the HIV program, and we do need to integrate both into one. So there's a major disconnect, and then M&E is crucial to ensure that we have a successful program. Next, please. 30 seconds, I know. Okay. So we have these conclusions, but I will highlight the fact that capacity building is critical, okay, especially among clinicians, because it's not in our medical school curriculum, it's not in the postgraduate curriculum. So the clinicians that will see the patients tend to miss them. We need local leadership and champions. We need sustained availability and accessibility to antifungals and diagnostics. It's very crucial. And then we need new partnerships that are key to ensuring the full package of AHD care is accessible for all across all sectors and all settings. Next. So we need new partnership. We cannot overemphasize it. It's crucial for this war to ensure that we win. We've come a long way. We have had a lot of successes, but these new partnerships will ensure that we have sustained success and we have goals that we can reach and exceed. And then we need them for comprehensive package of care for all who need it. The next slide. I thank you for listening to me. And so straight away, we'll go into the first panel discussion. I would like to call up, next slide. I like this next slide, yeah. Okay, so I have 5 panelists here. We want to look at the lessons from the country level implementation of AHD package of care. The first is Dr. Marvin Masango from Eswatini National AIDS Program. Okay, and then James, thank you, welcome, from Chai. Dr. Samson Humba from Georgetown University. Martin Mugasha from iSolution, I think is joining us virtually. And then Dr. Lydia Mpago from ECPA, very passionate about the pediatric group. Welcome. Okay. So, who took mine? Thank you. So go straight into it. The focus of this panel discussion is to focus on the experiences in planning, procuring, delivering, and access to the AHD package of care from national program perspective. And our conversation we aim to voice how countries prioritize the components of the package of care and highlight specific challenges, maybe records, tell us their successes, and then highlight the specific challenges in implementation that have resulted. And how do we go forward? What's the way forward? So straight away, I think I'd like to start with Dr. Marvin Mansango. And I'd like to ask you this question. Maybe you introduce yourself first, to us what you do, and then I can ask my questions.
Thank you. Afternoon. I'm Marvin Masango. I'm with the Eswatini National AIDS Program as the National TB HIV Technical Advisor. Over.
Thank you. So, Marvin, we noticed that Eswatini made significant progress towards achieving the 95 goals and has recently introduced comprehensive guidelines on AHD. And I say, well done. I think that's great. So what do you see are the most significant country needs to fully implement these guidelines? And how do you see Eswatini replicating their success with 95 in achieving the AHD goals?
Thank you for the question. So I think maybe I'll just give a brief background. As highlighted, Eswatini is one of the first countries to achieve the 95 targets. But despite that, we continue to see a significant proportion of patients presenting with advanced HIV disease, almost 1 in 3 of those new patients coming into care. And we mainly, see that, in newly diagnosed HIV clients were diagnosed with HIV but not linked to care, patients with high viral load but on treatment, but also treatment interrupters who, then come back to care. We've made so much progress in rolling out AHD. I think we started in 2018 with the support of CDC Foundation. But however, we still see some gaps. But I think back to the question as to what do we need to do or what do we need to achieve our AHD targets. So I think one of the main important pillars is leadership and coordination of advanced HIV disease care in the country and also at all levels, national level, but also subnational levels. And in my country, I think we have done pretty well. This is coordinated under the TB HIV office where I sit, and we have a multidisciplinary team drawn from various sectors that reports to the care and treatment TWG. And I would emphasize that this is key if you want to implement AHD. Secondly, I think policies and guidelines remain key. Advanced HIV disease should really be strong in all your national strategy documents, as in your national guidelines. We do have that, and I think that has allowed us to push the agenda of advanced HIV disease in my country. But we still have aspects that we want to update, especially in our standard operating procedures and job aids. The third would be capacity building of healthcare workers, both clinical, but do not also leave out non-clinical cadres. I think the need for training in most countries will be an ongoing need, and you'll find that in our experience has been that it's easier to reach out to other cadres, but it's difficult to find doctors, and that remains a key gap. We also want to include advanced HIV disease in our curriculum of our training colleges, as well as to tap into some innovative training platforms. I think at the moment, AgPath is leading an online training hub where we also want to upload advanced HIV disease training modules. The fourth one would be we need to strengthen our supply chain for both diagnostics and also therapeutics, advocacy for funding, but also to ensure that there is a stable global production as well as access programs and good lead-in times. The fifth one would be decentralization of service. I think we will never be able to achieve our targets with centralized services and advanced HIV disease, and I think someone is going to talk about it. We have also rolled out, point of care tests, and we need point of care tests to be that point of care and not to be sitting in the lab. And I think the sixth one is community engagement, extremely important. And, health education, we should not leave the communities behind. And I'll say maybe the last one would be a strong and robust M&E plan. We need to be able to account for inpatient and outpatient services in terms of advanced HIV disease. And also, like said earlier, we need not only national targets, but also global targets on AHD. I think for now, that's what I have to share.
Thank you. Dr. Sampson, as a key PEPFAR implementing partner, Georgetown has served as the central support partner to Eswatini's Ministry of Health. What role do you see implementing partners taking in ensuring access to AHD services? That's one. And then two, where does this fall within the scope of the PEPFAR mandate? And in what capacity can implementing partners continue to assist beyond this in the future?
Oh, sorry. My name is Samson Haumba, Country Director for Georgetown University in Eswatini. I'm also an Assistant Professor of Medicine at the same university. Thank you for the question. As rightly said, Georgetown is a PEPFAR implementing partner and has been working closely with the government of the Kingdom of Eswatini to scale up AHD services. And if I can speak for all implementing partners, the first and key role for implementing partners is technical assistance in policy guidelines development, in development of SOPs, as well as the tools that can be used for advancing AHD based on the WHO package and other experiences within the country. So as an implementing partner, we look out for the newest evidence and work with our national program partners to either adapt or to adopt what is current, but what is feasible within the country, but also to advocate. Sometimes you might find that there are certain resources within the country which can be mobilized towards implementation of these guidelines and SOPs. When we talk about access, we need to make sure that the guidelines and policies that we develop are client-centered, that every client who needs the services is able to receive those services. And the services really include the diagnostics. So how do we introduce and support the new diagnostics for CRAG, for CD4? As you know, at one point, CD4 was the main test for in HIV, but now viral load has taken over, and so some programs have fallen back in terms of promoting CD4 testing, and yet that's how we diagnose AHD. In Eswatini, we've been able to support the rollout of the VISTEC technology for CD4. But there are also other tests, TB LAM and so forth. So the testing itself, that's the entry point. Then the second point is the access to medication. Some of the medication is centralized in the major hospitals. So how do we roll it out to the lower facilities where most of our clients are found? But also, as a regional clinical partner or national clinical partner, we do a lot of trainings and retraining of staff, also doing mentoring so that we can support their confidence in both the treatment, because we know, for instance, cryptococcal meningitis has its own nuances in terms of treatment, and we need to monitor the safety of some of these medications. But also importantly is to establish the patient support system, especially patients who interrupt treatment. How do we ensure that we find them and bring them back to care? And those are some of the patients who will come with advanced HIV disease. But above all, is to support the whole continuum of care, including supporting documentation so that there is information at local and national level that can help us to track and report AHD, but also supporting learning, implementation science, and bringing the evidence to improve guidelines. As PEPFAR, where is the mandate as a PEPFAR implementing partner? We know that in the COP 2023, a specific section 3.1.16 talks about reducing mortality as a major thrust for PEPFAR programming. And the groups that have highest mortality, we have the patients with HD, we have the over 50, and we have the under 5s. So specifically, for the patients with AHD, PEPFAR is providing resources to implementing partners to ensure that we cover the gaps. And some of the gaps have already been addressed by Dr. Masango. But how do we see our support going forward? So the support could be through advocacy at national guidelines, but also inclusivity of the other players, for instance, the private sector, to support those areas where we do not have the mandate as a PEPFAR implementing partner, or PEPFAR is not supporting sufficiently. Thank you.
Thank you. Lydia, can you tell us about the AHD services? What can be done to ensure that the pediatric and the adolescents are prioritized in the future? AHD services in your country, how do we prioritize adolescents and children? They seem to be a group that is ignored, in quotes. And then also, what will it take to meet the needs of this group and others that have not benefited from interventions in the past?
Okay, so thank you. Good afternoon, everyone. My name is Dr. Lydia Mpango, and I'm a Senior Clinical Services Advisor with the Aspire Project to Elizabeth Glaser Pediatric AIDS Foundation in Eswatini. So thank you very much, Rita. I think that one of the things that we really need to do across the cascade of pediatrics is the issue of data availability. I think that that's something that has been echoed throughout the discussions that we've had this week. And this data needs to be disaggregated even within the realm of PEDS. When we take a look at a lot of our national data, it's less than 15, more than 15. But when we talk about AHD, even with the under 15s, the packages of care are going to be different. So we really need age disaggregated data. As Rita said, we need targets. And this also goes specifically for the pediatric population, because within the populace of our treatment current, the patients who are identified to be on HIV positive, our pediatrics take such a small portion. So we really need to have pediatric specific targets. We also need to understand that this population is lagging behind, not just in AHD. When we take a look at our different programs, whether it is malaria or it is TB, or looking at immunization, it is still our pediatric population that is lagging behind. And I think during the talk about ending AIDS by 2030, we had a really very powerful speech that talked about the silos within the different programs. So we really need to work towards coherence and optimizing our systems and our funding across these different programs, specifically targeted to the pediatric population. We also need to make sure that we involve children in catalytic research and investments. And I think that we have very many examples where this has worked. In EID, we have got our point of care. When we take a look at the CAP TB and the work that it was done, we have done really very, very well. And currently, ECPAF is working on an AHD toolkit specifically for children that we hope to see within the first quarter of next year. We need to improve our diagnostics for children. I think that Rita also alluded to this. And we need to empower communities in order to be able to provide support, both technically, and also we need to provide them with funding and a space for them in order for them to play their role in prioritizing children and adolescents. In response to your second question, which speaks to meeting the needs of those that have not benefited proportionally from interventions in the past, I think multi-sectoral collaboration is something that has also echoed across, and we do have an opportunity under the Global Alliance in order to do this. Resource mobilization and optimization specific to children, and also coordination with the different donors that we have within the pediatric space. Health system strengthening, and this really speaking to the Stop AIDS strategy for children, unpacking it, because the Stop strategy has got many different components, and those components belong to many different program areas. So we need to make sure that we're able to unpack it and also raise literacy and ownership within the community space. Task shifting in order to improve access, and also strengthening the integrated framework in order for us to support those programs at national all the way down to community level, especially because children go through different transitions. They will move from infancy to childhood, childhood to adolescence, adolescence to adult, and throughout those cascades, they are re-engaging and disengaging from care. So we really need to think about it from the pediatric space. I was really happy with the previous presenter who talked about fixed dose combination for TPT for kids, because I think that that's something that also would help us in the future if we had formulations and diagnostics that are tailored for adults being made suitable for children. Thank you.
Thank you so much, Lydia. Your passion came across.
Thank you.
We hear you. Okay. James, maybe you should introduce yourself before I load you with questions.
Thanks, Rita. Hi, everyone. Good afternoon. Thanks for sticking with us on a hot afternoon. James Conroy, I lead our AHD work at CHI, and that work has been, over the last kind of 4 or 5 years, supporting AHD implementation in 10 countries with support from Gates and Unitaid. So hopefully some top tips that I can share on implementation that we've seen.
Okay. So CHI supported my country in the work they did, and I think they did an exceptional work. Thank you. So what activities and approaches have been most instrumental in these successes?
Thanks, Rita. Yeah, so I as we were listening to our colleagues on the panel, a lot of what they've covered, I also had on my list. So I'll try and synthesize this into kind of four main buckets of lessons that we've learned in supporting these countries. I think the first, my colleague Lisa Tini spoke to on just strong national-led AHD leadership and governance from the offset. And what does that look like in most countries? Well, where it's been most successful, that's been a dedicated AHD technical working group chaired by the Ministry of Health with all the key partners around the table. And by key partners, I mean PEPFAR and Global Fund from the offset, community and civil society from the offset, implementing partners in the districts where you're planning to implement your AHD implementation. And that all might sound relatively obvious, but there is a really strong correlation between the regularity and the attendance at those meetings and how successful AHD programs have been. And so I would really encourage really encourage that. The group that we shouldn't forget, which often gets, I think, left out, in almost all of the countries where we're working on AHD, there is a group of dedicated people who have spent the majority of their life focusing on advanced HIV disease, often in research settings or in academic settings. I'm sat next to a very esteemed one on the panel, and they can provide such a motivating and important role in those technical working groups. And so I would encourage all programs to be utilizing that passion that is in country and the expertise that's already in country as well. So that was bucket one. Bucket two, I think, is around the actual implementation strategy themselves. We've seen two approaches work really well. One in Nigeria was a kind of phased AHD implementation, so focusing on 4 high burden states to begin with. And of course, the benefit that gives is it allows countries to understand a little bit more about the burdens they're dealing with, the new products they're introducing, and then as they take that to the national scale, implement those lessons learned. And that's been really, really impactful. The second is a hub and spoke kind of approach to AHD screening and implementation. It's unrealistic to treat cryptococcal meningitis at 100 facilities in a country. It's a very complicated disease. And so having a screening approach that is more decentralized and then a hub approach that is more treatment focused has been really impactful in the countries where we've worked. The third bucket is really thinking more about a kind of early AHD diagnosis and a plea, I guess, to the comments that were made from colleagues at the end there to really focus on CD4 screening. It has dropped off, as was mentioned, as we've reprioritized viral load for very good reason. But we do need CD4 to diagnose AHD. It's the gateway to the cascade of care. And whilst there are some dynamics in the market at the moment, we do have tools available to decentralize access to CD4 and still provide quantitative results where needed. So I would encourage programs to not forget that, obviously alongside CRAG screening and TB-LAM. And then finally, just to talk a little bit about commodity access and procurement. The market is relatively fragile for a lot of these commodities still. If we're talking about the treatment commodities at the end of the cascade, those are quite low numbers when we compare them to anything we're used to in HIV, like ARVs or HIV testing. And so thinking about that and how that can then impact how we order and how we procure. So things like scaling up procurement relatively like phasely in different phases at the beginning. So maybe placing an order for a year and then reassessing 6 months in and going again. And also giving as much lead time as you can to some of these suppliers who aren't manufacturing these products constantly every month. Often they're having to manufacture to demand. And so the longer lead time we can give on orders, the shorter lead time for the delivery of the product. So there's lots of others around M&E and training and other things, but I think I'll pause there.
Okay, so I'll just ask you one additional question.
Sure.
And I'm throwing it in there. You talked about a spoke and hub.
Yeah.
And a lot of work did provided guidance was in screening, right? But you also said when it comes to management, it's in the hub. Was capacity built in the hub for this?
It's a great question. And I think there's 2 parts to that. The first part
is critical. That's what I'm trying to say.
Yeah, and you're totally right. Yeah, of course. And I think we can't underemphasize the level of effort that is required and resources required to ensure that training takes place. The other part to it in that cascade that you mentioned, where we see enormous drop-off in Nigeria as well as other countries, is between the positive CRAG LFA test and the patient getting to the facility for a lumbar puncture if a lumbar puncture happens. And so, investments and efforts focused on linkage from as positive screening to the hub facility and then through the diagnosis and treatment is critical.
Okay, so I will also leave the rest of us to think about it, because we need to come up with solutions for the inpatient care, and these solutions have to be cost effective. The previous session talked about the fact they needed 4 billion and then they ended up getting 0.9 billion. So we have one more presenter is joining us online. Martins, how are you?
Doing fine. Can you hear me loud and clear? Loud and clear?
Yes, we can. Can you introduce yourself, please?
Yes. So, so glad to be on this panel. My name is Martin Mugisha, Senior Category Manager at iPlus Solutions. So my role is to oversee all our procurement and sourcing activities for all the projects we support, largely the Global Fund and a few others that come along at that chain. I've been working in the HD space largely with James, actually. I could coin the word partner in crime, because we've really been at the forefront of trying to bring product in country and work in the upstream in the markets to try and ensure that the HD products are available. And largely I'm talking of the pharmaceuticals.
Okay, so can I ask you this? So how have countries adopted their forecasting and procurement to Global Fund's guidance on HD, and what do you feel is needed to strengthen this?
Yeah, thanks for the question. So I think it varies from let's say the categories of the countries. I must say that for the countries that have had technical support from the likes of Chai, have really adapted very well. And of course, these are largely the high impact countries. And for those countries, basically, you could think of things like, timely order placement, because as James mentioned, the market, was a little bit volatile a couple of years ago. And even right now, you still have some, single sourced items. So literally ordering on time, having demand visibility is very key to ensure that, the commodities arrive in country at the right time of implementation. So I think countries that have had some bit of technical support in that sense have adapted very well. The Global Fund has tools like the lead time planning guide, sort of that guide countries, to order, product when and such that they can determine at what time, the product will arrive in country. That's the good side. On the other side, the countries that have not had this sort of support, that's sort of a very big challenge. So ideally what happens is then you'll have, demand coming in from the countries, but it's not predictable. It's not something that you can actually count on, and you don't have visibility as well. So as you plan to, and as I+ Solutions, we have the role to work with the suppliers to actually plan not only demand for the Global Fund, but also talk about demand from the other implementing partners like PEPFAR, MSF, etc. So what happens is then it's very, very difficult to then prioritize orders if you really don't have that predictability in demand. So I must say it's sort of a mixed bag, but I emphasized indeed that the countries that have had some technical support have actually done very well, so to say. And leading to, the next question on how can this be sort of strengthened? I think that there's so many tools out there. So the Global Fund, I think, has indeed rolled out a lead time planning guide. So countries can actually, order these products based on a lead time planning guide that can give them a precise timeline upon which they can expect to receive, of course, the products. And that is, of course, if everything goes smoothly, because as we know, once you place orders, some things may happen along the way, but at least there will always be a feedback loop on why things are delaying. But I think that's one of the core thing that needs to happen for countries. So adhering to lead time planning guides, and as James has mentioned, one of the things we've advised the Global Fund is we've built in at least sufficient, lead time that can cover, let's say, the worst case scenario. So what you have on the lead time planning guide is more or less, give or take, accurate. The other thing that I see that indeed can help change is indeed technical support. There's a couple of countries that we know are high impact, but we do not see demand, and we're actually employed to sort of put them into consideration as we discuss forecasts with suppliers, as we try to determine what model suppliers can change in order to ensure that we have a shorter turnaround of orders. So we've been thinking about building some stock models for certain key products. But for you to do that, then you need you need to have almost visibility of all the high impact countries at the correct time, and you can relay this information to suppliers. But again, so you have sort of some countries doing very well, but then those that you would expect, they are not really up to that speed yet. So and maybe it's a difference in training, or it's a difference in technical support. And I think that can go a long way. So if there is some, technical support at national level for some of the other countries that do not have the likes of Chai on board or Elizabeth Glaser, etc. on board, then I think, yeah, if they could get some technical support, I think that can go a long way, because ideally, I think with that support in forecasting and planning, I think that information then seeps through to the funders like PEPFAR and Global Fund, and then it comes to us that can plan the supply adequately.
Thank you so much, Martin. Thank you. That was very insightful. And I would like this session, we are short of time, but it's been very, very informative. And I hope it will start off conversations that will take it to the next level, so that we'll come up with the way forward. What do we see going forward? Do you think we need targets for AHD2? It's not a different program, it's inside the HIV program. How do we integrate both? So I think we'll have those in the questions, in the further discussions. But I'd like to thank my panelists, Marvin, who just became my best friend recently, James, Lydia, and something. Thank you so much. Thank you. So we'll have our questions and answers after the second session.
Yeah, thanks everybody for sticking with us again on as James said, a sweaty afternoon here. But at least we're not in the Sapphire room. So yeah, so we're going to kick off with our second panel session. We'll have Rita again as our fearless moderator, and really great to hear from some of our program implementers and folks working at the country level to hear about some of the progress that's been made and some of the continued gaps. Now we're going to hear from some of our panelists who are working on some potential for collaborative solutions. And I will hand it over to Rita. And from there, also, as she said, we'll go into a question and answer. So save your questions till the end.
Okay. Greg, thank you. So this session is going to focus on novel approaches to multi-sectoral partnership that can potentially address both national and regional challenges by filling in the gaps in the current HD funding landscape. It's a tall order, but you're up to it. Okay, and then the main points we want to focus on: what are the gaps that remain in PEPFAR and Global Fund support for the HD package of care, and then the role of multi-sectoral partnerships and what solutions they will offer to address these gaps, and then leveraging private sector resources and strengths. Also, how do this multi-sectoral partnership, how can they be structured and built into mutually beneficial and sustainable ways to acquire new novel approaches? Okay, and so to discuss this, some of the experts on the field with lots of experiences. And so I would like them to introduce themselves. Google, I'll start with you. Could you introduce yourself?
The mic. Yes, I would like to introduce myself as Guguletu Madonsela from Eswatini, from the National AIDS Program, where I work as the TB HIV focal person. I work with Malvin, in that same office. Thank you for having us. Thank you for giving us this opportunity where we'll be sharing our experiences in terms of implementing AHD, mainly focusing on involving the private sector. Thank you.
Okay, so we know that Eswatini partnered with NGOs like the CDC Foundation, and more recently with the private sector on AHD activities. What did you see as a critical component of partnership with these non-traditional funders? And what would you like to see more in the future to strengthen AHD service delivery in your country?
Okay, thank you very much for that question, Rita. But in responding to this question, I just want to say I agree with what you